Good evening. Good evening, madam, and a warm welcome to all of you. We are moving slowly but steadily. Okay, as we have been telling, pain forms a very important element. You will come to know through it. Nearly, they say pain and breathlessness covers 80% of the issues of palliative care. So for that is why we have had a extensive time and discussion on this. And on that front, I would welcome Dr. Mary Abraham, who is a neuroanesthesiologist and a pain and palliative care physician, whom we have been introduced to, and because we have enjoyed the amount of knowledge and information she shared on the initial stage of when we were talking about pain. Now, last but not the least, when you've learned about it and you still have a difficult situation, how are you going to manage? That's what she's going to take us through today. She is a busy practitioner in New Delhi, and she's also been awarded the Lifetime Achievement Award, and her main interests are neuroanesthesia and pain and palliative care. And she's also authored a book with the title Conquering Pain in 2019. With that, I hand over it to you, madam, to take us through the session for today.
Thank you, Radha. Thank you, Shri Priya. And once again, it's a pleasure to join you this time. We are moving ahead and seeing how to handle difficult pain. Because by now you must be knowing about the 3-step ladder, but there are cases which cannot be handled by that. And that is the when you're faced with a dilemma as to how to proceed. So I'll try my best to go through that with you. And I would like to share my screen. Just 1 minute. Just go on.
We can see, madam, just if you get it to the slideshow.
Yeah, I've got
it. Yes, it is on now. Thank you.
Okay, so here we go. So what is difficult pain? So like I told you, with a 3-step ladder, you can treat about nearly 75% of patients with cancer pain. But there is a segment that is still difficult to treat, which constitutes around 15 to 20% of patients. So for them, we have to do something which is more than the WHO 3-step ladder. And these are the patients who have got refractory cancer pain. The other terminologies the other synonyms for that are intractable pain, persistent pain, or opioid non-responsive pain. So what is the definition of difficult pain? This is pain related to cancer or its treatment of at least 3 months duration that has not responded to standard treatment with opioids and co-analgesics. There are some risk factors why people land up with intractable cancer pain. So these are listed here. One is young age. Neuropathic pain is more difficult to treat. Incident pain. See, there is continuous pain and there's incident pain. Continuous pain is easier to treat. Incident pain is more difficult to treat. Then when there is psychological distress, or where there's a history of previous opioid use or tolerance to opioids, again, they may be unresponsive to the opioids. Or where there's a history of addiction. Impaired cognition, that is another place where we have difficulty in treating the patients, probably because they cannot express their pain and, we have a difficulty understanding the extent of their pain. Let me start with a case scenario, and then we'll try to see how we analyze this particular patient. This was a 62-year-old man with CA rectum. He had peritoneal and liver metastasis. He was on chemotherapy since 1 year. He developed acute intestinal obstruction with pain in the abdomen due to progression of the lesion. He was taken to the ER by his family and admitted for conservative management of intestinal obstruction. A Ryle's tube was inserted and colostomy was done. And the surgeons at the treating physician decided not to continue with any chemotherapy. Surgery also was, he was not fit for any kind of surgery. So they did a colostomy and he was discharged with the advice of continuing with palliative care. Initially, he was taking step 1 and step 2 drugs through the nasogastric tube, along with adjuvants for pain abdomen. But the abdominal pain persisted, and then he had to be moved on to step 3 drugs. And this was being given through the oral route because he had a Riles tube syndrome. But one day he pulled out his Riles tube and he did not want it reinserted. In fact, even when it was put in the first place also, he had objected to it. And now he certainly didn't want it reinserted again. So there was a family discussion as to how to feed him, as he had become extremely emaciated and weak. And also we wanted to know how to give the oral opioids also. Because without a Riles tube, it was very difficult to do that. But because we respected the patient's wishes, and that is patient autonomy, we decided not to reinsert the Riles tube. So he was started on IV fluids through schemoport. But the pain grew worse, and then we put transdermal fentanyl patch at 25 mics per hour with oral transmucosal fentanyl citrate or OTFC, that is a fentanyl lollipop, which has a strength of 200 mics. That we were giving him SOS. But there was no relief, and he was in agonizing pain. The family was extremely distressed. So what do we do next? So at the end of my presentation, we'll just try to analyze this and find out how best to handle this patient. So when you look at the steps of handling difficult pain, the first and foremost is we have to review the situation all over again. Probably we missed out something. Okay. So we review, then we have to manage based on our review. And that management could be either pharmacological or non-pharmacological. So the pharmacological is by converting the route or by rotating the drug or by adding further adjuvants. Non-pharmacological could include interventional pain management, psychological therapy, physical therapy, alternate therapy, and even spiritual therapy. So when you have to, first I said, you have to review. So it's easy to remember it with this mnemonic ABC. A is adherence to treatment. Is the patient adhering to the treatment that you are giving, or is there something that is being missed out in the treatment that you're prescribed? We need to check on that. I'll come to that in the next slide. The second is B, which is you have to believe the patient about the pain. If the patient is having pain 10 out of 10, we have to believe it. It was Margot McAfee in 1968 who said that pain is whatever the experiencing patient says is existing, whenever he or she says it does. In simple terms, pain is what the patient says hurts, and we have to believe them. Then we have to do a comprehensive pain assessment. For that, we need to go through the pain characteristics, which I remember I told you about PQRST. And then we have to look at the functional history. How active is he? Is he mobile? Is he able to carry on his activities of daily living? Then review the prior drug and non-drug history. Examine the patient and review again. So that is how we do a comprehensive pain assessment again. And then, last but not the least, we have to correct the correctable factors. It could be an underlying infection that's flared up, or it could be a pleural effusion or an ascites that has got worse. And then there could be insomnia, because insomnia can reduce the pain threshold. There could be anxiety. There could be he's not taking food properly. His nutrition must have deteriorated. So we need to correct these correctable factors. Anemia, etc. we have to look into. Now, to check for adherence of treatment, we have to first review the analgesics that is on and review the adjuvants that he's taking. We have to check the patient's understanding of the dose that you have prescribed. We use teach-back techniques. What is that? For example, if this is a prescription, we'll ask them to tell you, either the caregiver, who's the primary caregiver of the patient, ask them that how are you giving the medications? Then he will tell, we are giving paracetamol 3 times a day or morphine every 4 hours, and then SOS doses, whether For breakthrough pain, are they giving it in the way that you have told to do? Are they, what about the bisacodyl? You ask them to read it back to you and see whether they're following what you have written. That is called teach back techniques. Now, there are certain reasons for opioid ineffectiveness. The most common reasons are accumulation of toxic metabolites of opioids, or progression of the disease, which is very common, why the opioid has now become ineffective, or is there a new pain type? I mentioned in my class that we have, besides nociceptive pain, there could be other types of pain also in patients with cancer. It could be neuropathic, it could be spasticity, it could be bowel obstruction, it could be due to lack of sleep. So many reasons are there where there is another pain besides the nociceptive pain. So we have to see whether there is anything like that. Or are the side effects of the opioids intolerable? For example, have they developed neurotoxicity? Because if they do, then you cannot escalate the dose of morphine. Or is there a failed route of administration? Is there a poor oral absorption? Or if there is intestinal obstruction, again, the absorption is not very good, or the transdermal skin absorption may not be all right. Or there could be if there's a catheter or a pump or a needle, is there a problem with that? Is there a malfunctioning of that, which is known to occur? The catheter can get misplaced or it can get blocked, and pump can also not function properly if there is a PCA pump on. So all that is the route of administration failure. And then, last but not the least, are there underlying psychological, social, or spiritual factors? So these are the various reasons why your drugs are not, why the patient is landing up with intractable pain. So how do you manage it? I mentioned about the pharmacological and the non-pharmacological. So let's look at the pharmacological management. The first is we may need to manipulate the opioid that is being given, either by a route conversion or a rotation, which is called an opioid switch. Or we may need to add an adjuvant, like we may need to either add an anticonvulsant or antidepressant, or maybe we have to escalate the dose. We may have to add an NMDA antagonist, antispasmodics, or local anesthetics, or maybe corticosteroids, or even cannabinoids. So we may have to add an adjuvant also. So coming to route conversion. In route conversion, the same opioid is given, but the route is changed. For example, if the patient is on oral morphine, you may have to convert it to intravenous or subcutaneous morphine. Or if the patient is on transdermal fentanyl, you may have to again change to IV or subcutaneous fentanyl. Now, serum concentrations can be achieved by both IV as well as subcutaneous route. And both morphine and fentanyl can be given through both routes. But please remember the conversion factor. That is, oral to subcutaneous to intravenous is 3:2:1. So 30 milligram morphine orally is equivalent to 20 mg subcutaneous and 10 mg IV. So please remember the conversion factor when you're changing over to parenteral morphine. Or you can give morphine as a continuous infusion, and that is for continuous pain. But if there is incident of breakthrough pain, then there is an added facility of an intermittent bolus. Okay. So we have got patient-controlled analgesia or PCA pumps that can be used for both continuous and incident pain. These could be either disposable, they are the elastomeric pumps, where in this balloon you fill in the drug, the morphine or whatever you want to do, and then it will be administered at a particular rate depending upon the pump characteristics. It could be 2 ml per hour or more than that according to the different ml per hour pumps are available. Or there is this pump, this is not disposable, this is called the CADD pump or the continuous ambulatory drug delivery pump. In this, there is a small place where you have to inject the drug, and that goes according to the rate that you set. And there is also a remote by which you can give a bolus dose if required. So so there is also a continuous basal infusion and also the facility to give a bolus dose for breakthrough pain, which the patient can self-administer. So these are the PCA pumps. Now, there is no evidence of the superiority of parenteral versus oral opioids to control intractable cancer pain, but the European Association of Palliative Care recommends the use of parenteral opioid infusions in case where oral or transdermal opioids fail to provide effective analgesia. Although there's no superiority, we can still recommend that we may have to switch over to the parenteral. The next way of opioid manipulation is called opioid rotation. This is also called an opioid switch. How do you do it? It's the different opioid is given, but the same route. For example, oral morphine is changed to oral methadone. So we are rotating the opioid. So what are the indications for opioid rotation? It is intolerable side effects like neurotoxicity or poor analgesia despite titration of the drug. And how does opioid rotation work? It works because we all know that there is cross tolerance between the opioids. If you give one, and the second one also there could be tolerance. But there's a phenomenon called incomplete cross tolerance. And because of that, when you switch the opioid, there are some receptors which are able to which are available and which work and they can produce the analgesia. That is called incomplete cross tolerance. So another opioid can be efficacious where one has cost tolerance. So this is that greater than anticipated potency with another opioid. So when converting from one opioid to another, there are 3 steps that you have to keep in mind. First of all, you have to look up the equianalgesic table to find out what is the equianalgesic dose. An example is if a patient is getting 60 milligrams of morphine and you want to switch over to fentanyl, then the equivalent dose is 25 mics per hour fentanyl patch. So once you've calculated it, then you have to reduce that by 50% for well-controlled pain and 25% for poorly controlled pain. This is to account for the cross tolerance. And lastly, please prescribe a rescue dose as well, because if the pain, there's a breakthrough pain, then you may have to give a rescue dose. That also has to be prescribed. I think all that would have been dealt with in the class on step 3 analgesic drugs, I presume. So what is the opioid-induced neurotoxicity by which you cannot escalate the dose of opioids? They manifest as sedation, delirium, myoclonus, hallucinations, hyperalgesia, and seizures. And the cause of this neurotoxicity, the side effects of morphine is because of the metabolites that are morphine 3-glucuronide and normeperidine. So in India, the other opioid, strong opioid that's available to switch from morphine are methadone and fentanyl. So that is the only 2 step 3 drugs that are available in India. Outside, you have got other drugs also, but that's not available in India. Now, methadone is inexpensive, can be given orally, but they are all under the same legal control as morphine. So the advantages of methadone for difficult pain are that it is a step 3 drug, it's very potent, it is effective for neuropathic pain because it acts on the NMDA receptors and it is also a serotonin norepinephrine reuptake inhibitor. So by both mechanisms, it can be effective for neuropathic pain. It has no known active metabolites, unlike morphine. It has a long half-life, about 8 to 12 hours, slowly eliminated, so there is less risk of breakthrough pain. It does not accumulate in renal impairment, so can be given in patients who have got renal dysfunction. There's less tendency for tolerance and no cross tolerance, and the cost is also relatively low. But it has got certain disadvantages. One is there is a high potential for accumulation and delayed toxicity. There is a risk of life-threatening ventricular arrhythmia, particularly if there is QTC prolongation on the ECG. and that is called torsades de pontis. And then titration is difficult, so the risk of overdose because of half-life is variable. And very important, it has to be given only by experienced palliative care specialists only, and not for the novice in palliative care. So what are the indications of methadone? First of all, as an opioid switch drug or rotation, it can be used. It is very inexpensive. It is least expensive of the long-acting opioid drugs. It can be given when there's true morphine allergy, when there is neuropathic pain, and when there's renal dysfunction. But the contraindications, when there's a QTC prolongation, avoid it. When there's no reliable caregiver, when there's history of sudden unexplained death in the family, and also because of the drug-drug interactions with azithromycin, fluconazole, and amitriptyline, you have to be careful. So if you want to convert from morphine to methadone, that is opioid switch, then if the patient is taking 60 milligram oral morphine a day, then the equivalent dose of methadone is 2 to 7.5 mg per day. If the patient is taking between 60 to 199 milligrams of morphine, and if the age is less than 65 years, then you have to divide the total dose of morphine by 10, and that will give you the dose of oral methadone. But if the patient is taking more than 200 mg morphine, and if the age is more than 65, then the conversion is divided by 20. Now, the methadone is available as 5 milligram tablets or syrup of methadone 5 mg per ml. So as per expert consensus white paper, the equi-analgesic dose suggested for methadone is very conservative. So we need not account for incomplete cross tolerance. So we do not have to reduce the dose, unlike other drugs. So switching to morphine from methadone from opioid analgesics was shown to be safe and effective in one prospective controlled study of opioid-tolerant cancer patients. The other strong opioid that you can give for cancer pain, particularly those who are not responding to morphine, is buprenorphine. So this is also an option for opioid rotation. It gives good relief, good tolerability. It can control neuropathic pain and breakthrough pain better. The transdermal route, we have got patches available of 2.5 mics per hour, 5 mics per hour, 10 mics per hour, and 20 mics per hour. Each patch you can keep for 7 days. Nowadays, sublingual tablets of 20 mics are also available, and the effect lasts for 6 hours, especially useful for breakthrough pain. So buprenorphine, you can give it as patches as well as a sublingual. So when you want to convert morphine to buprenorphine, then if the patient is taking less than 30 milligram per day morphine, then you can start with a 5 mics per hour patch. If the patient is taking between 30 to 80, then you can start with 10 mics per hour patch. We can supplement the this patch even when you're taking the morphine for breakthrough pain. So it's useful for breakthrough pain as well. If the patient is taking more than 80 milligram of morphine, then the patch may not be effective. Even the 20 mics per hour patch may not be sufficient. So we have to look for other ways of giving. So let's discuss what is breakthrough pain in cancer. Now, breakthrough pain, which is an intermittent episode of extreme pain, breaks through the opioid regime that the patient is on. The patient is getting, say, 10 milligram morphine 4 hourly, but the pain occurs in between the 4 hours. That is called a breakthrough pain. It is not lasting even as long as the duration of action of the drug. So this can occur either spontaneously, but more commonly it's due to movement of the affected limb or bearing weight on the tumor-bearing bone or walking or any activity. The incidence of breakthrough pain can be as high as 80%. So we need to prescribe drugs for the breakthrough pain. And for this, you usually have to give a fast-acting, short-duration opioid. So for this, we have Oral transmucosal fentanyl citrate or fentanyl lollipop. The strength is 200 mics and 400 mics. Do not use more than 4 units per day. How is it given? It should be sucked over 15 minutes and not chewed. So keep it in the mouth and just suck it for 15 minutes. Effect starts in 30 minutes. It lasts for 2 to 3 hours. Sublingual buprenorphine 200 mics can also be used as a treatment for breathing. Now, having discussed the various drugs and options for treating intractable pain, we must also see the cause of the pain. Is it nociceptive or neuropathic, or is there a need for an adjuvant drug? Okay. So I had mentioned about this, that nociceptive is due to tissue injury, and anything beyond the tissue is called the neuropathic pain because of the peripheral nerve or the spinal cord or the brain. Okay, but very often cancer pain is mixed with both nociceptive as well as the neuropathic element. Now, in difficult neuropathic pain, what are the options that we have? One is ketamine, because it blocks this NMDA receptor, which is in the dorsal horn of the spinal cord. Now, we know that ketamine can be given through a variety of routes, but when you have a patient with difficult pain, it has to be given generally IV or subcutaneous. So we have what is called the burst ketamine or the pulse course of ketamine for treating difficult pain. So how do we do it? Patient has to be admitted in the daycare under ECG monitoring. A syringe pump is taken and 100 milligram of ketamine in 24 hours is administered through the syringe pump. You give that for 3 days. If that is not effective, then you escalate the dose to 300 milligram per day for another 3 days. If that is not effective, you can go up to 500 milligram in 24 hours for 3 days. If that is not effective, then we have to stop it. So this is called a burst ketamine, which is used for treating intractable pain. We know the side effects of ketamine that has to be kept in mind. So they can manifest as dysphoria, hallucinations, nausea and vomiting, dizziness. You can prevent it by giving haloperidol or adding a benzodiazepine like clonazepam or midazolam. Local anesthetics can also be given for difficult neuropathic pain. Like they act by decreasing the neuronal excitability at the level of the sodium channels. It is reserved as a second-line treatment for treating severe intractable crescendo kind of neuropathic pain. So you can give it as an IV local anesthetic infusion. We have to load 5 milligram per kg Xylocard in 500 ml of normal saline and give it over 1 hour through the bottle itself. You can give it over 1 hour. But the effect is transitory and we have to monitor for CNS and cardiac side effects. It can be repeated after a few days. So this can be given to treat neuropathic pain. Also, topical patches are available now, lidocaine patches. I mentioned it in the last class. So other topical drugs to treat neuropathic pain are topical capsaicin or topical gabapentin. This can be used as supplements in addition to the treatment that you're doing. So if you look at the neuropathic pain ladder, this I also mentioned, the first line is amitriptyline, pregabalin or gabapentin, duloxetine and lidocaine patch. The second line is opioids like methadone and tramadol. And third line is baclofen, mexiletine, capsaicin, ketamine, and cannabinoids. So let's discuss cannabinoids in difficult cancer pain. Cannabinoids has been used for various ailments since ancient times. But in medicine, the use is restricted because of legal and social concerns because of drug misuse. But a few symptoms in palliative care can be resistant to some of the current options that are available in palliative care. And although there is absence of robust clinical data, whether there is really a risk-benefit ratio, so it is not included in the palliative care treatment, but we can try it as an option. So cannabinoids act on the CB1 and CB2 receptors in the central nervous system. Now, CB1 receptors are found in the brain, the spinal cord, the nerves, leukocytes. They're poorly expressed in the brainstem, and that is why there's low incidence of respiratory depression with cannabinoids. So it is a CB1 receptor that causes the well-known psychotomimetic effects or the euphoric effects of cannabinoids. The CB2 receptors, on the other hand, are mainly found in the immune system. They do not have psychotomimetic effects, and they are now being investigated for therapeutic effects like the analgesic effect, the anti-inflammatory effect, and even anti-neoplastic effects. So the two phytocannabinoids that have been extensively studied are the THC, that is a tetrahydrocannabinol, and the CBD or the cannabidiol. Now, nabiximol or Sativix is an oromucosal spray containing 1:1 combination of THC and CBD. Now, THC acts mainly on the CB1 receptors and CBD acts on the CB2 receptors. This has been found to be well tolerated with improved analgesia in opioid unresponsive cancer patients. So what are the cannabis preparations that are available? They can be classified into THC dominant, THC with CBD, or CBD dominant. The THC dominant are the synthetic ones like dronabinol. Okay, so that can be given by the oral route, 5 milligram of THC per capsule. And the other one is nabilon. That is also a synthetic THC, and that is given oral route 1 milligram in one capsule. Then you have this combination of THC and CBD, like I mentioned last time, nabiximol, which has a oromucosal spray. The dose is 2.7 milligram THC and 2.7 milligram of CBD. I said that this has been found to be effective in some opioid-resistant patients. And then we have the CBD dominant one, which doesn't have the psychotomimetic effects. It has only the analgesic and anti-inflammatory effect. So that is a cannabidiol, which is oral preparation, 99% pure oil, again a dose of 5 milligram per kg CBD per day. So if you look at the cannabinoids for cancer pain, the analgesic effect is definitely weaker than strong opioids, but comparable to weak opioids. So after 15 to 20 milligrams of THC, the peak effect is reached in 3 hours and it can last up to 6 hours. So the dose has to be given every 6 hours. So it can be used as a third or fourth line treatment for neuropathic pain when other conventional therapies fail. It's also used for chemotherapy-induced nausea, vomiting. The ones that are given are the dronabinol and the nabilon. These are both THC-dominant cannabinoids. So I won't go through this because this is for nausea, vomiting. So now the cannabinoids have certain side effects. One is the neuropsychiatric effects, then the impaired cognition because of excessive sedation and impaired neuromotor skills. It can also have an infection risk because it reduces the host response. And there could be cardiovascular side effects like hypertension, hypotension, tachycardia. So you should avoid in patients with heart disease. In palliative care, it can be used as a third or the fourth line treatment for neuropathic pain, can be used for chemotherapy-induced nausea, vomiting. Then it can be used for cancer anorexia, it improves mood and antipsychotic effects also. And also it has anti-cancer activities. It can treat sleep disorders and it can be used for seizures as well. Now, medical cannabis in a study published in 2022, it was found that it caused significant improvement in pain measures and a decrease in other cancer-related symptoms and reduced the consumption of opioid-based analgesics. And they said the side effects were minimal. So this was a recent study of medical cannabis in cancer patients. But in India, what is the status of cannabinoids? Is it legal? We know that abroad it is being used to treat neuropathic pain and multiple sclerosis and refractory pain and cancer. In India, There was a petition in Delhi High Court challenging the provisions of NDPS Act, because NDPS Act says that cannabinoids are illegal. So they wanted that it should be legalized for medicinal purposes. So there was a petition in Delhi High Court, and the central government has informed the court last year, not this year, last year, that use of cannabinoids is allowed in India for medicinal and scientific use as per law, and it is not completely banned. So that is the status of cannabinoids. Just 1 minute, please. Hello, Ashish, I'm in a class. I'll talk to you. Corticosteroids. Now, we know I talked about this in the last class, so I may not have to go through this, that how it is used for a variety of pains, particularly even refractory pains, you can use it. So dexamethasone is a first-line drug, and it has been found to provide short-term relief of pain. So it's particularly useful for those with decreased life expectancy. Then about the GABA receptor agonist, we know about the GABA A agonists, which are the benzodiazepines, out of which clonazepam is useful, and GABA B receptor agonist is baclofen. So baclofen has also been used for refractory neuropathic pain. Bone pain is another cause of refractory pain, and I did mention the various drugs that we can give, agents that we can give for bone pain, which includes corticosteroids, NSAIDs, bisphosphonates, and denosumab, and palliative radiation. Now, malignant bowel obstruction, octreotide. This is a very important cause. Malignant bowel obstruction is an important cause of refractory cancer pain. And octreotide is a synthetic hormone. It's a somatostatin analog. How does it act? It decreases splanchnic blood flow, portal blood flow, decreases the GI motility, gastric, pancreatic, and bowel secretions are decreased, and increases water and electrolyte absorption. And that is how it can help in intestinal obstruction. How do we give it? 3 mics per hour for 24 hours as a continuous subcutaneous infusion for 6 days. And they have said that it is now the drug of choice in malignant bowel obstruction. It can be combined with steroids and hydroxy. Now, having discussed the pharmacological option, what are the non-pharmacological options? They include nerve blocks, that is a step 4, nerve blocks, epidurals, PCA pump, neurolytic blocks, spinal cord stimulators, intrathecal infusions. Okay? So that is the step 4 interventions that we can use. So PCA pump, here I mentioned all this. The neurolytic procedures can be either chemical neurolysis, thermal, or surgical. And intrathecal procedures, so they are useful in patients where they have severe side effects from the drugs and whose life expectancy is more than 3 months. There are also some neuroablative procedures like neurolytic procedures, celiac plexus block, superior hypogastric plexus block, ganglion impar block, particularly for patients with rectal cancer and in the perineal region, stellate ganglion blocks, or lumbar sympathetic blocks, or even intercostal blocks, and trigeminal neurolysis. So their neurolytic procedures like neuroablation can be done for these. There are also central neurodestructive procedures. These are very rarely done. They include rhizotomy, gangliotomy, chordotomy. Of course, these are surgical procedures and has to be done by the neurosurgeon. But this is very rarely done because they are very high-risk procedures. The risk-benefit ratio should be assessed before attempting any of these procedures. The non-pharmacological therapy also may need to be added on in these patients. So some of the options available are dry needling, acupuncture, biofeedback, psychological therapy, physical modalities, spiritual therapy, and alternate therapy. So these are patients with cancer patients. You can use dry needling because of the muscle spasm that happens because of the pain, and they act by relaxing the muscles. They cause reflex relaxation of muscle and improves the hypoxic local energy crisis because of the sustained contraction, sustained spasm, and it releases a trapped inflammatory mediator. That's how dry needling acts. Physical therapy, There are a variety of things that you can try out, and they can be used to supplement whatever we are doing, not as a standalone therapy. And many cancer patients have a lot of psychological and spiritual issues. They've got fear, anxiety, depression, anger, guilt, financial issues, concern about the family, even questioning God. So we have to support them psychosocially and spiritually by counseling, communication, medications may need to be added, and then forming support groups, and of course, alleviating their financial concerns as well. So having discussed all the various options available, let us review the cause of cancer pain in that particular patient that I discussed in the beginning. So he was gone into intestinal obstruction, and then he was advised palliative care. He had a colostomy. He had pulled out his Ryle's tube. So what were the causes of pain that had happened in this patient, which was unresponsive to even transdermal fentanyl? One was medical reasons. Could the disease have progressed? The colostomy site definitely looked unhealthy. Second, there was a failed route of absorption, and there was a decreased transdermal fentanyl absorption. But were there other psychosocial concerns as well? So what was done? We readmitted him to the hospital. Colostomy was found to be non-functional. In fact, it had become necrotic. So that was the obvious cause for severe pain. So an opioid route conversion was done. We switched over from transdermal to intravenous fentanyl infusion, along with supportive care. The pain subsided gradually. End-of-life care was instituted, and this was explained to his relatives. The patient expired free of pain 2 weeks later. But have we been too drug-centered or intervention-centered in our approach? Have we reviewed other non-pharmacological interventions that could have been done? Now, what were the psychosocial concerns in this patient? He was a highly educated retired doctor. There were no financial concerns because he was completely covered by insurance. He had a supportive family, his wife and daughter. The wife was a main caregiver, and she had taken over the role of the head of the family. But despite all that, he was depressed because he knew that there was no cure and he would not live long. So there was a sense of hopelessness, helplessness, and powerlessness. He had psychosocial problems as well. Because of the COVID and because of his cancer, he was not meeting anybody. He was isolated from friends and relatives for more than 2 years. So he was experiencing loneliness and isolation. Then he had a low self-esteem. He was totally dependent on his wife, even for self-care activities, like change of the colostomy, the care of the colostomy, and for his own personal hygiene and everything. He was totally dependent on his wife. So he had a low self-esteem. He also had a sense of guilt. His family had given up all their activities. The wife had given up a job so that she could become his full-time caregiver. They were not having any socialization. So he had a sense of guilt. And there was a role reversal as well. His wife had taken over all his responsibilities, financial, medical, everything she had taken over, and he was left helpless. So he felt that as head of the family, he's a helpless person because his wife had taken over everything. So like I said, sometimes when the step 3 drugs fail, then we may have to switch over to the interventions like intrathecal opioids or the PCA pumps, or even go in for the neuroablative procedures. But along with that, at every step, we have to give psychosocial support as well. So we can consider palliative sedation like what was done for this patient, but never desert the patient, even if your treatment fails. Like palliative care at home failed, but then we took him to the hospital and ensured that he was comfortable at the end stage of his life. So we have to be fellow travelers in their difficult journey. We can be frank about a failure, but we should convey it with sensitivity. They will understand. Even the relatives will understand. But the psychosocial spiritual support has to be continued till the end of life. And also any worsening condition should be treated. So that's the end of my presentation. Thank you very much for the patient listen.
Thank you very much, madam. Just one thing, there was a message that Sonu Bhavati, Dr. Sonu Bhavati Ilangovan had some issue with the voice, but there was no problem. I could listen all along, so I did not stop. So Sri Priya, just double check with her if she's okay still.
Sure.
Okay. Madam, really, you have took us through, because these will be the queries which will be in everyone's mind. What do I do if the patient comes back still with pain? So ma'am has given you a clear, like a guideline, step 1, step 2, step 3. Only thing, as we always keep telling, follow this sincerely and review regularly. And no need to jump into changes. If you do too many changes too frequently, still you will not get any benefit. Okay. Sometimes, as she mentioned, no, that oral and IV will have intravenous and things will be the same, will give the same benefit. That has to be conveyed to the patient. Give them assurance that we will try for another week. That's all. You don't carry on like 4 months telling that, oh, you have to carry on like that. You won't get. That is not what I'm trying to say. It's just to be patient with the patient, and your patients does come, and then explain to them what it is, how it is, and what are you going to tell them, that we have other options also, so that gives them some confidence, that you're not letting them, oh, this is the only way out. If this doesn't work, there's no other way out. That's not the situation. But at the same time, switching so often may not give you the benefit. These type of things have to be conveyed. And as you have had a full session today, go through each one of them, double check, because many times 4 hours and all, we say, how often do they follow? Because they may have some other things going on. There may not be anyone to give, the patient may be bed bound. There may not be anyone in the house to give it every 4 hours. So the patient might have had it at 8 o'clock in the morning, and the next dose goes in only 6 in the evening. So these type of issues, no, they may feel something difficult to express. So see, these are things only, as we say, no, you get into that patient's shoes. So how will we be comfortable to say, oh, am I going to let down my family, or am I going to let down my carer? So many things may be there. So please, if there is some issue, go into that and see properly. That is where social worker, nurse, everyone will come handy. Sometimes, no, many of them will be hesitant to tell to a doctor. But to a nurse or a social worker, they will tell you, think, oh, this is what it is. But I felt difficult to tell it to the doctor when she asked. Tell me if anyone has not faced anything like that. It is very common. And one thing I wanted to ask, madam, regarding this OTFC, I have used in Adyar Cancer Institute. But recently, sometimes I have been hearing that the availability of OTFC is not that easy. How is it? Is it available freely?
I'm not sure about it. I had got some samples actually from the company.
Because I have used it.
So I don't know whether it's freely available. I'm not really sure.
We'll have to double check with that alone, because I have used it a lot, especially if a patient is having difficulty. I would give that to the patient, ask them to sit in the outpatient itself for some time, and then it'll settle down. And then all these type of things, giving IV or these type of things, we have tried. And OTFC I have tried, but recently I heard the availability. We have to confirm, is it freely available? So because it's a very good of preparation or formulation, which will come handy. And because it works immediately, the patient from score 10 by 10 to at least 3 or 4 by 10, they will come, which is a big difference. So that is one thing I wanted to ask. And then maybe, see, in this group, there are many people who have morphine available. So if this OTFC also is available, is something all of you could have a look into it. And one more thing, CBT is the non-pharmacological method, which Madam mentioned, cognitive behavioral therapy, which is very, very useful, which will be a tool which will be used by the psychologist this is something similar, no? How we all work around. It is how your thinking is having an influence on the way you do anything. And
Yes.
by just remodifying it,
Yes.
you can get wonders out of it.
The
It's all there,
thoughts,
like
thoughts affect the behavior, behavior affects the emotions, and emotions
exactly.
affect your thoughts. So it's a
It's a
three
cycle.
skin:
It's
thoughts,
a
behavior,
cycle.
emotion.
So that's a cycle, and then it will have an impact on so many of your physical, emotional, everything can change in that. So, and again, I've been telling all through this pain sessions, low mood, high pain. Okay, that is a standard that has been proved by fMRI studies. I'm not just telling out of the blue. Okay, fMRI studies have proved all this. That
Can you just tell that again, Radha? Can you just tell that again?
Low mood, pain is high. Whenever your mood is low, your pain is high.
Yeah, that is there. The gate control theory itself will tell that. No? That anxiety, low mood is opening the gate for the pain to go up.
So this one, not that it is just said, it has been proven by fMRI studies that they have seen people who have these type of low mood, and they have done focal MRIs where blood flow changes are there. Many things have been seen. So there is a strong connection to that. It is just not here where it's just said or something. There is evidence to that also. So that is why the psychological counseling and all does have an impact.
And if not psychological counseling, as a palliative care physician, even reassurance is so important. By just reassuring the patient, half the pain will go. And that is not talking out of my hat or anything like that. It is true. Just reassurance and telling them you're looking good and things like that makes so much of a difference to the patient.
Yes, that's all. See, spending few minutes, because see, many times what happens, these patients, everyone has to have their own life. We are not blaming anyone or anything at all there. Because see, that person might have been the breadwinner. Okay. So without money, I generally say, will any shop give you free rice and milk? No one in any part of the world will do. Okay, these are gold standard statements. So at least for that, you need money. So if this person, the patient was the breadwinner, someone has to earn for that family to survive. So they, at that point of time, they may not, the person who loves them may not have the time to speak. If she speaks, who will earn? Those situations. So there only our role comes. You being there for them and reassuring them, okay, even if this is not possible, there's another way. You ring us. So like, I'll give you some examples. See, for example, in Adyar, when I was working, what will happen is we will do the regular patient seeing. And we will have a phone and we will tell them, you can ring us 9 to 5. In between me seeing patients, I will answer phone calls. Either me or the nurse will answer and listen to their queries and give solutions for them. So 9 to 5, we will have that service also. That's being done everywhere. Even Palim has a telehealth service. So these are not only Palim, everyone has, even in many centers in India, in Chennai also have it. So those are things which you can have one more option like that. So people who are all thinking of doing palliative care services, even that mode will help. So because even though they can't come, they are far away, but by phone call, for example, I'm having vomiting, they might have skipped, they might have not taken the tablet like antiemetic. You take the antiemetic 45 minutes before taking anything. These type of advice. So whenever you do a prescription for morphine, if you don't write at this beginning, by the clock, you give it clear instructions on, we will write the time, 6:10 to 6:10, everything will be written, what dose. Then antiemetic for first 3 to 5 days, even you don't have vomiting, please take. So if they take like that, then after 4th or 5th day, they won't need it, then use it when required. Then if you have to prescribe laxative, that was stimulant like. So like that, this one drug, your prescription is incomplete if you don't have all the rest what I've said now. So like that, you have to check on everything. And then are they taking it comfortably? And then dose titration. Then you have drug rotation. So see, so many steps are there. You will be able to find some ways and means of giving pain relief. And again, 8 out of 10 you may do. The 2 rare outlier will be there where you use the other modes. And generally also one thing to have in mind, total pain. So consider all 4 elements. And then from the beginning itself, try to do some amount of multimodal management. This is something very, very important. That multimodal management will help each one. It's like working in a team. When you work in a team, the workload is shared. So the same thing, pain burden also is shared in that. So some emotional element is taken care by the counseling. Some physiotherapy helps with the physical movement. So when they can get up, walk, do something, so that, see, all that, this whole hopelessness, helplessness, I am unable to do anything, I am a burden to everyone. These are things which you take some of that away, even 50% pain might go away. See the human being inside. Okay, so that's all. So I've just added some beautiful words, madam. The main important thing was your information.
And other thing is, when a patient comes, just don't focus on the pain. You have to, like psychological issues you've talked about, ask them what kind of food are they eating, how often are they eating, what about your bowels, are you moving it regularly? Or many patients have a sense of fullness in the abdomen. They say that we don't feel like eating and we feel bloated. Huh? So, or they may say that I don't get sleep at night. So these things also have to be handled. It's not that you're only giving the pain medication and some antidepressant. That's it. No, you have to see maybe that eating habits are not okay. Maybe they're constipated, or maybe they're feeling full, fatigued. So this is what is total management of the patient. Don't just stick to, I'm a physician, I check about the pain and the actual physical symptoms. The total pain management is everything, including their diet. What are they eating? You can tell them that if you're feeling bloated, don't eat 3 meals a day. Eat 5 small, frequent meals a day. Simple. Small meals, but eat it 5 times. That will prevent this bloating. Maybe add a perinorm. There's so many things that you can do to alleviate that kind of thing. So that is important. Please don't focus on only the pain and the physical symptoms. That's very important.
That's what Sir Dr. Rajgopal himself used to say. Don't say case. So see the person inside. He'll say this case, that case. He doesn't like that at all. That is true, isn't it? He used to say, what you look at that person inside. So that's what. Overall, see the patient as a whole. That is something which will be very useful. And anything else, the intervention, all those things, no, there are many like things. Again, everything has to be appropriate. Just because everything is there, you need not try and do everything. Okay, because everything has its own plus and minus. The interventions also, not that one intervention will work for everyone. So, and is it appropriate, risk-benefit ratio in all those things? Patient is so sick, can't move, you force them on anything. Is that going to benefit them more than what they are or how they are? Is there no other way out to deal with their situation? All that has to be looked into. That is the way forward to look into. And then there are multiple ways of managing. Go in a methodical fashion and you will be able to solve the issue to a certain extent so that the patient is comfortable at the end of the day. That is the main aim. Okay, in that case, we can go on to case presentation and come back for the discussion if anything more is there. As far as I've seen the chat, nothing else is left unanswered, madam.
Okay, fine.
Sorry for that. We are sharing the correct list.
I was about to.
Sorry, ma'am. The PPT was changed. Sorry for that.
Yeah, you have to get today's present. Thank you, Shripriya.
And
Good evening.
Yes, go ahead, doctor.
Good evening, Radha ma'am and Mary Abraham ma'am. I shall be presenting a case of CA pancreas with liver metastasis with obstructive jaundice. She was having chronic severe abdominal pain, which was radiating to back. So she presented with the severe epigastric pain, which was radiating to back, along with nausea, vomiting, constipation. She was having jaundice, itching all over the body. It was associated with lost weight, lethargy, and weakness. It was a known case of CA pancreas for which she underwent some surgery. Nature of the surgery was not known because she was not having any record, and she underwent chemotherapy 3 years back. But since last 1 year, she had recurrence, and for that again chemotherapy was given. The pain was radiating from the epigastrium towards the back, and it was basically a neuropathic pattern of the pain. And she was already on oral morphine 100 milligram per day, 40, 40 and 20 in the afternoon. And she was using transdermal fentanyl patch along with this, but still she was having pain, VAS score of 6/10. The reason for this increase in pain in last couple of days was because of she was unable to procure morphine because of availability issues for since last 4 days. For that, she was experiencing more severe pain and also suffering from the abstinence symptoms. When she presented to us with the VAS score of 9 or 10/10, and she was offered hospitalization, for which she accepted, and she was hospitalized. On examination, she was conscious, oriented to time, place, and person, and she looked unwell, in distress, and she was crying and agitated. She was poorly nourished. There was ictus was present. She was looking frail with poor muscle mass. There was pedal edema. There was scratch marks over body at various locations. Pain score was 9/10. Her vitals were BP was 112/60 and heart rate was 102 with a respiratory rate of 18. She was afebrile. Chest CVS was basically normal. Investigations, she was having jaundice, liver, and alkaline phosphatase was 744. And on the CT scan, CCT, she was showing that there was a metastasis in the liver, as well as there was a CBD was dilated, probably because of blocked stent. Electrolytes and all those things were within normal limit. Hemoglobin was 7.8. Next, please. She was put on oral pregabalin 150 milligram BD, paracetamol 1 gram QID, intravenously diclofenac 50 milligram TDS, and fentanyl infusion was given, which was titrated to achieve a VAS score of 3/10. For that, we required an infusion of 100 microgram per hour of the fentanyl. We planned for a celiac plexus block and a diagnostic celiac plexus block with local anesthetic and steroids was given, and a patient had good relief with that, and it was not associated with any significant side effects. On the next day, we gave her neurolytic celiac plexus block with the absolute alcohol at L1 level on both the sides. That helps in decreasing the pain. We were able to lower the fentanyl infusion to the about 50 microgram per hour by the 24 hours, and this we gradually tapered the paracetamol and all those things also. And on the third day, she was discharged from the hospital with a transdermal fentanyl patch of 50 microgram per hour, pregabalin 300 milligram per day, and amitriptyline 25 milligram at bedtime, and lorazepam 2 milligram at bedtime. Various socio-psychological aspects associated with in this patient. This patient was having matrimonial disharmony because her husband was alcoholic. He used to beat her up. There was poor family support, no one to look after. She was anxious, depressed, and there was disrupted social circle. She was feeling concerned because she was unable to devote time to her only daughter. She is 10-year-old, and there were definitely financial issues as she lost her job, and husband was also not earning well. Apart from giving the celiac plexus block, we give her a psychiatric consultation, and gastro consultation for block stent was offered. And we followed this patient for 3 months. Even after 3 months, patient was having a good pain control after celiac plexus block with a VAS score of 1 to 2 microgram, and she was continuing with transdermal fentanyl 550 micrograms per hour along with the adjuvant drugs. So main concerns in this patient were severe pain and difficulty in getting prescribed opioids, fear of death, fear of future, and upbringing of her 10-year-old daughter, and various psychosocial issues like lost job, financial issues, and matrimonial discord. So to sum up this case, this was a 46-year-old ex-school teacher who was a known case of CA pancreas with liver metastasis, with obstructive jaundice, with chronic severe pain, anxiety, depression, and she was admitted for control of pain, and we offered her neurolytic celiac plexus block, and that helped her in relieving symptoms of pain. So most of the discussion points are already well discussed by our worthy speaker today, Dr. Maria Brown, about the advanced pain management, psychosocial support, palliative care, and supportive or symptomatic treatment for the jaundice or stent or itching, nausea, vomiting, etc. Thank you very much.
Thank you very, very much, Doctor. You have like the appropriateness of the case to today is that you like always good things first. See this, any pancreatic or liver issues, no, the pain is very, very intense. Morphine is a gold standard in that, again, only by practice and seeing patients, I'm telling that. And especially young patients come in this situation, and they are a bit hesitant or scared of starting morphine. Also, morphine helps. But again, in this case, when it had reached a state, because see, 3 years she has had the disease progression, and so well managed with the neurolytic block is what, and that has been revealed in your case presentation itself. Because of that, see the amount, the medication, everything, she's been able to come down. Only one query was running in my mind. The fentanyl, how was she managing? Were you providing her with the fentanyl patch all along?
She was,
or was she buying?
She buys it.
Oh, then that is costly, isn't it? So,
Yeah,
like, again, your center is a government center, or?
She was in severe pain, so that's, and she was off, she was advised fentanyl patch, and she was somehow arranging it herself.
Oh, okay.
Because
That is really...
ours is a private institute. And the patient has to buy from the pocket.
Okay, okay. That is what was running in my mind. Because see, no source of income for her. when she's not well and things. She was not working, am I right?
She was presently not working. She was initially school teacher in a private school, but she has had to leave her job because of her disease.
So that's what. So financial concern will be very high for her. And that high financial concern will have an emotional and psychological impact too. And she's got a 10-year-old child to look after. So good, some form of support, counseling, and finding someone who could help her are the things by the social worker or some system which will help is NGOs is something which will be very helpful. And so that's what. So nutshell, the difficulty was there and the interventional procedure helped her and at least gave her some physical pain relief, which could help her with finding or sorting her own life with whatever was available for her. Or anybody else, I will pass it on to Madam first to take us through whatever she wants to convey, and we'll get it open for the whole team. Maybe we can come out of the screen, Sri Priya.
Yes, ma'am.
So I would say this case was pretty well managed. That and it shows exactly how when step 3 drugs fail, how escalating to step 4 by giving a neurotic block really helped the patient. So much so that you could discharge her and she could come down to one basic minimum drugs that was there. So I think it is pretty well managed. And the problems that she now encounters is her own future, future of her child and the family, psychosocial issues that she has. The physical pain has been taken care of very well. And other issues are still there, looming in front of her. That is the child who's such a young child, the husband who's having his own issues. So that's going to be difficult. The other thing is, you said about psychiatric consultation. Somehow I feel there is no need of a psychiatric consultation because the psychiatrist will only put on medications. I think that, the medication you give as a palliative care person, along with psychological issues, is all that is required rather than taking a psychiatric consult. That's my opinion. I don't know whether.
Thank you, madam. Yes, you were right. I had missed that. That psychosocial is what is needed than the psychiatrist.
Because if you go to a psychiatrist, I'm not bringing down psychiatrists, but they will put on so many medications that they will become drugged. Whereas we ourselves are giving so many medications to treat depression. Okay, so that is sufficient. What she needs is counseling, psychosocial support she needs rather than a psychiatric consultation. That's the only thing I didn't agree with in this.
That's totally true. Well, what is your opinion, Dr. Sunit, also? Because see, as madam said only, I would also feel because if see again, it is individual patient based. If a patient has had some previous history of psychiatric issues and things like that, then the question is totally different. So those type of patients stopping or reducing anything and all will have impact on the general day-to-day living.
This present problem is related to her cancer. Her anxiety, depression, fear is all cancer related. It is not because of a prior psychiatric illness.
My concern for psychiatric consultation in this patient was she was depressed and she somehow expressed that she wants to die, something like that at one moment. So that was the only concern.
No, that will be there for anyone. This all, see, when the slides of madam, which had many things in red, That is an important slide.
Very, very
Okay.
important. Guilt and low self-esteem and role reversal and
See,
hopelessness,
that
helplessness, and
slide
everything
is
will be
very
there.
important, madam. One more reason also why.
Yes,
Because when you all had the ethics session, remember Dr. Sangamitra telling about Being Mortal book. That book will have all this in that book also. Okay. It will tell these are the reasons why someone feels like that. So they are interrelated. I don't, we are not questioning you, Dr. Sunit, at all, but just bringing forth that all this situation, that's why I generally say the palliative care, it's a very sensitive situation. Okay. Sensitive, secretive. Some things we will find it very difficult to reveal. See what things will be going on in their mind when they are diagnosed with stage 3, stage 4 malignancy. What will happen to, one is what will happen to me, what will happen to this 10-year-old child, if I'm not wrong, girl child, right?
Yes, yes, yes.
See how much will be running in that mother's head. Father is one who is not even looking after her. Okay, then only the father is going. If a father had looked after the wife, then she will have confidence that the father will look after the daughter also. Whereas, unfortunately, poor female, she has not had that confidence and faith in the first place. That's the situation. We will not go into that because that we can talk for hours. We will not go there. So there itself, she's not had the confidence. So these situations, she will feel, oh, I'm in a catch-22. I cannot manage. I don't know how to manage. So one thing is running out of the situation. That is where you get the idea of committing suicide and things. Okay. So that is the reason. And so some psychosocial support. And then finding, hopefully, next thing, what I always tell in all my sessions is, there are people outside in the world who want to help, okay, but they don't know whom to help. Whereas we have trouble in different forms in our hands. It is just finding a link between that organization or person who wants to help and this who is in need of help, combining both. So that is something all can think about it. That's where the social workers will come handy. They will be the link between our demand and the supply, which is already available, especially education, doctor. Many people are willing to fund for education in today's world. Finding that person who is willing to fund, and you have this person who needs the support. So that is something, no, there will be groups. That is where, no, if you do little bit more research or spend time to find that NGO who is willing to help and link this person who, that is what Pallium does a lot. They do a lot with, especially with education for children. And that takes away the biggest fear, burden from the patient or family who are in this situation, and that will help with their pain management, and that transforms the life. For this female, you just get someone to help the child. Everything else, she may even go to work, like she may do something at home to fund herself, and she will help more. So those are things which we have to little bit more. It's not only as we have been discussing today. All of us are doctors, I don't deny, but again, all of us can think we have been benefited with so much knowledge. So if you spend that time a little bit more to find out links or go a little bit extra mile, you can find some things like this, some links, and then connect. You need not do all the work. You just connect. That's where a social worker will come very handy. You put these ideas into your social worker's mind. You go find someone, then we have got it. Then that's how the, and that is why, no, I think all of you, it will be worthwhile for you to visit Pallium and be there for a couple of days to know how these things work. So once you see to believe, then you can say, oh, it's not that all it's told in thin air. It can happen. It is there, not only there, like I mean, the places where I work, there'll be some private organizations. You can get them to come to your institution once a month. Something like this group setup, or those are things which you have to think, work out of the box and see how you can help. So, and one more question was there in the chat about the how long celiac plexus block was effective in this case. I think after 3 months also, it was a neurolytic block. Then in that case, it was, it lasts longer. Madam, you want to add anything more to that?
It usually stays for about 6 months to 1 year, 6 months, depending upon if you are giving opioids along with it. Its effect is prolonged pretty well.
I think, thank you, Dr. for answering. There's one more question. How to give reassurance to patients who are terminally ill as they are in a very hopeless condition? Do we need to sometimes lie to them? No, not required. There only you should never lie. You will, don't ever lie, don't ever give wrong reassurance. Okay, you will have all that dealt with in your communication sessions, which will come along. Why you have to, it is hard, but the thing is that in all those situations, you have to give reassurance to them that you will take away or help them with all the symptoms which can be taken away. For example, nausea, vomiting, constipation, all those things we will take care of. And then for them, even for very sick patients, there are something called as chair exercise, sit, stand exercise. These are things which the patient or the family may not know. So like that, you say, that is the reassurance, and then talk to them. See, main thing, time. You have to spend time and talk to them. In your 2 minutes, quick, all that won't work. Okay, you have that. What is that is bothering you the most? You may be thinking pain. That may not be the answer many times. Okay, if you ask this question, what is that is bothering you the most, then you will get a different answer. For that is what you have to give reassurance. So see, I don't deny they are in a situation, and then many times, no, they themselves will know how bad is the situation. They will tell you many things which you will be hesitant to say. I know I'm going to die, but I want to make sure how this can be dealt. Then you deal with that. Don't assume. Don't assume that this is what they, that's why, again, no, I won't steal the beauty of your communication session. No. So that's what you will be dealt with in great detail in your, you have 2 sessions for communication. So you will all get answers for all your queries. And that was that. Is there anything else? Let me check. Yeah, that's it. So so overall, I think all the chat queries I have answered. We have answered, madam. So I think that's it. Anything more anybody wants to ask, please unmute and ask, or I will hand it over to Sri Priya. Oh, there was some hand raised. No, it was there and then it has gone off now. Okay. Okay, Sri Priya, I think I'll hand it over to you.
Thank you, Dr. Mary Abraham. It has always been a pleasure listening to your sessions. And as usual, you just amazingly took us through this wonderful session. Thank you so much. Thank you everyone for joining in the interactive discussion. And we do hope that you are learning something new in each session. So with the promise that we will meet in the next session with another different topic and at another very interesting faculty. This is Sri Priya along with Dr. Mary Abraham and Dr. Ata Venkateshan signing off from the Tipsico Hub. See you in the next session. Till then, everyone, take care.
Thank you very much,
you.
madam. Thanks a lot.